Hello, guys. Welcome to Pharmacy Made Easy. Are you struggling to urinate? Waking up multiple times at night? A constant feeling that the bladder isn't empty? Sound familiar? For millions of the men over the age of 50, these are not just the minor issues, they are warning signs of something deeper. Although the term benign prostatic hypertrophy is still commonly used, it is actually incorrect because the prostate does not enlarge due to hypertrophy but due to hyperplasia. Let's break down the differences and why understanding this is a crucial for interpreting the benign prostatic hyperplasia correctly. You might have heard the term benign prostatic hypertrophy used when referring to the BPH. But here is the truth. The term is scientifically inaccurate. The correct term is benign prostatic hyperplasia because the underlying pathology involves hyperplasia, not hypertrophy. So, what are the differences? Hypertrophy means that existing cells growth larger in size. There is no increase in number of the size, just an increase in their volume. This is commonly seen in skeletal muscles, like when you build a muscle from the resistance training. For example, lifting a weight can cause us a muscle hypertrophy where muscle fibers swell in the size due to an increased protein content. Now, hyperplasia, on the other hand, means an increase in the number of the cells. The size of each individual cell does not change, but the total tissue mass grows because more cells are produced. In the benign prostatic hyperplasia, the stromal and epithelial cells of the prostate undergoes hyperplasia. They multiply, leading to the enlargement of the prostate. This increase in the cell number causes the prostate to expand and compress the urethra, which is what leads to the classic urinary symptoms in the older man. Now, let's see about the testosterone. In the male body, testosterone, the primary androgen, is produced mainly by the testes, contributing about 90%, while the adrenal gland account for the remaining 10%. Once in the circulation, testosterone enters the prostate cells, where an enzyme called type 2 5 alpha reductase convert it into more potent androgen, that is dihydrotestosterone or DHT. This DHT then bind to the cytoplasmic androgen receptor, forming a complex that moves into the nucleus of the cell. There, it triggers the change in the protein synthesis, ultimately promoting the growth of glandular tissue within the prostate. This mechanism is key to understand one of the most effective BPH treatment. The drugs like finasteride and dutasteride are known as 5-alpha reductase inhibitors. They block the conversion of testosterone to the dihydrotestosterone, directly targeting one of the main drivers of the prostatic enlargement. Now let's take a closer look of the tissue composition of the prostate gland. The prostate is made up of two main types of tissue. First one is glandular or epithelial tissue. This portion is responsible for producing the prostatic secretions, including the prostatic specific antigen, that is PSA. And the second type of an tissue is stromal or smooth muscle tissue. This surrounds the urethra and contracted when stimulated, playing a key role in the urinary obstruction. Here's what fascinating. While androgen like dihydrotestosterone promote the growth of the glandular tissue, they have no direct effect on the stromal tissue. Instead, research suggests that stromal hyperplasia may be influenced by the estrogens. And since testosterone is partially converted into the estrogen in the peripheral tissues, it may indirectly stimulate the stromal tissue growth, another contribute to the prostate enlargement. Finally, the stromal tissue is richly innervated by alpha 1A adrenergic receptors. When activated, these receptors cause the stromal muscle to contract around the urethra, leading to the obstructive urinary symptoms, even without the major change in the gland size. So, the enlargement of the prostate in benign prostatic hyperplasia isn't just about how big the gland gets, it's also about how tightly it can squeeze us. Now that we understand the hormonal and structural influences on the prostate, let's explore the pathophysiology of benign prostatic hyperplasia or BPH. The symptoms of the BPH, particularly lower urinary tract symptoms or LUTS, arises due to three main factors, and those are static factor, dynamic factor, and Detrusor related components. First, the static factor involves anatomical obstruction. As a prostate gland enlarges, especially around the urethra, it begins to narrow the urethral lumen, leading to reduced urinary flow. Now, let's see the next factor, that is dynamic factor. It is different, it relates to the smooth muscle tone. Here, overstimulation of alpha 1A adrenergic receptors in the smooth muscles of the prostate and urethra causes the muscle contraction, which further narrows the urethra. These tightening contribute to the same obstructive symptoms even when the gland size isn't significantly included. Finally, there is a Detrusor factor, a bladder based issue. Over time, due to the prolonged obstruction, the Detrusor muscle fibers, which help push urine out of the bladder, undergoes hypertrophy and eventually decompensate. This leads to a new set of symptoms, that is urinary urgency, frequency and incomplete bladder emptying. So, while obstructive symptoms like a weak stream, dribbling or a straining result from the static and the dynamic factors, but the irritative symptoms like urgency and the frequency are often due to the detrusor instability. And the fun fact here is the detrusor muscle contain alpha 1D adrenergic receptors, which is why certain alpha 1D blocking drugs like naftopidil is the closest to the clinically used alpha 1 blocker, and tamsulosin is a dual alpha 1 and alpha D block, making it effective for both voiding and storage LUTS. Now let's look deep into the tissue composition again. In a prostate enlarged by the BPH, the epithelial to stromal tissue ratio shifts to about 1 to 5. Androgens like dihydrotestosterone primarily stimulate epithelial hyperplasia but not the stromal growth directly. Stromal tissue is thought to be influenced by the estrogens, which is synthesized from the testosterone in the peripheral tissues. This is also why androgen suppressions with 5-alpha reductase inhibitors does not fully reverse the prostate size because they do not affect the stromal hyperplasia. Importantly, around 98% of the alpha adrenergic receptors in the prostate are located in the stromal tissue and 70% of those are in the alpha 1A subtype. This explains why alpha blockers, especially alpha 1A selective agents, are effective in relieving the urinary symptoms. Now let's summarize the symptoms. The obstructive symptoms include hesitancy, weak stream, dribbling, incomplete bladder emptying, straining to void. And irritative symptoms include urgency, increased urinary frequency, and nocturia. Over time, chronic obstruction may lead to the complication including acute urinary retention, bladder stones, recurrent urinary tract infections, hematuria, bladder diverticula, and even the renal impairment. So, what happens if BPH is left untreated? Well, the natural history is variable. Study shows that up to 38% of the men with the mild symptoms may experience the symptom improvement over 2.5 to 5 years, possibly due to aging adaptation, lifestyle changes, or simply tolerance. However, many other progress, especially those with the prostate size over the 30 grams of or PSA levels of 1.5 nanogram per ml or more. These patients are more likely to experience worsening symptoms, decreased quality of life, and complications like incontinence or urinary retention. In short, the prostate is dependent on androgens, mainly testosterone, for development, maintenance of the size and function. Testosterone is metabolized to dihydrotestosterone by 5-alpha reductase. Dihydrotestosterone is responsible for normal and hyperplastic growth, that is, increase in the number of the cells. Benign prostatic hyperplasia results from the overgrowth of the stromal and epithelial cells of the prostate gland. The layer of the tissue surrounding the enlarged prostate stops it from expanding, causing the gland to press against or pinch the urethra. These contribute to the lower urinary tract symptoms via direct bladder outlet obstruction and increased smooth muscle tone and resistance. The bladder wall becomes thicker and irritated. It begins to contract even when it contains a small amounts of urine, causing frequent urination. Eventually, the bladder weakens and loses its ability to empty itself. Now, and that wraps up this part of our deep dive in the benign prostatic hyperplasia or BPH. So far, we have defined what BPH is, a non-cancerous enlargement of a prostate gland that commonly affect the aging men. We explored its causes from hormonal changes to the age-related growth signal. We then walked through its symptoms like difficulty urinating, weak stream, and the frequent nighttime urination. We also broke down the pathology, highlighted how the increase in the number of the cells lead to the compression of the urethra, and the pathophysiology, which including the static and dynamic components affecting the urinary flow. And of course, we tied it all together with the relevant anatomy of the prostate and the surrounding structures. In our next video, we will take this discussion further as we cover how BPH is diagnosed from the patient history and digital rectal examinations to the PSA testing and imaging, and the available treatment options including medications, minimally invasive therapies, and surgical approaches. So if you found this video helpful, don't forget to like, subscribe, and turn on the notification bell so that you won't miss the next part in the BPH series. Thanks for watching, and I'll see you in the next one. Stay healthy, stay cheesy with Pharmacy Made Easy. Follow for more.